My name is Michael Janssen. I'm a spine surgeon in Denver, Colorado at the Center for Spinal Disorders. So in general, we see two categories of patients. Patients that just have some sort of an injury and have a specific history or identifiable event in their life that they think started this. And the second group of patients have no idea what happened. They just started developing pain, weakness, and at some point it becomes an impairment to them. And so they tend to present to a specialist in cervical spine problems. When I see a patient that has that problem, I usually tell them that they have three options. Number one, they can live with it. Number two, they can continue to treat the symptoms. What that means, physical therapy, chiropractic treatment, injections, medications, traction. Or number three, they can treat the structural problem. And I usually tell them the best time to think about treating the problem is when they don't want to live with it anymore. They've tried to treat the symptoms. It's not an annoyance anymore, and they consider it an impairment. And so they need to have what I consider two operations, but we do it all at one time. Number one, they need to have the pressure removed from the spinal cord and or the nerve. And number two, we have to put something in the space called a reconstruction. And in most cases, that's a fusion. Number one is the structural aspect of the bone. Number two is to have something that mimics bone in its pore size and its ability to remodel. And number three is to have some either cellular idea to induce or cellular activity to help bones heal. But historically, the treatment was to go to their pelvis and to take a saw and take a wedge of bone out of their iliac crest and then transplant that into the neck to give the right biological environment for them to heal. Bone morphogenic proteins create an environment to induce inflammation and to create bone. But you also have to control where the bone is. In the cervical spine, it's a much different than in lower threshold of making errors because we want to control where the bone heals and not just have bone heal in any area. I try to tell them in spine surgery probably has the least amount of evidence of these stem cells are going to have some actual physical property to help their condition. iFactor's an incredible technology that I think is completely different than the demineralized bone matrices, completely different than the BMPs, but yet it has similarities to BMPs because it's the only other technology that the company and the leaders have invested huge amounts of resources to get real data. Level 1 clinical data is very unique in spine surgery to begin with. And I could probably say maybe 4 or 6 clinical trials in spine surgery have changed to the gold standard or how we should assess things. Because level 1 data should set new bars or change the bar that we have in surgery. I think one of the biggest advantages of iFactor is we have to look at its safety and its efficacy, the clinical data, its handling characteristics, and what we can do with it. I think in my entire career, it'll be one of the most revolutionary things we've contributed to the literature on and to make a big difference in patients.